Thank you, Martin Vladimir, for having me again. I'm very happy to join in with this talk on Torcular meningiomas, and I think it actually follows a common theme of the last two talks. Martin Henry gave a fantastic overview of why venous anatomy in the P fossa is so relevant, and I hope I can build on that. Let me just see where we are. I have nothing to declare other than I think the only thing about Torcular meningiomas that is good is their rarity, because they are really scary lesions. Especially.
Can you put it in the presentation mode?
Oh, sure. Slideshow. Presentation mode. Yes, here we are. So my agenda is I want to take you briefly through epidemiology, more for completeness of purposes, then through some of the normal anatomy. I want to take you through the pathological anatomy and the problem, and then go over to pre-op management and imaging, followed by surgical management, including positioning, which I think is key, pre-intra-op and post-op strategy, and then 1 point on post-op management. So from background perspective, not different from any others, the brain tumor patients do not discriminate. There are approximately 700,000 people in the United States having a primary tumor, which translates into 78,000 per year, roughly 50,000 benign tumors per year diagnosed. And if you want to look up the different types of tumors, I provided a pie graph for you for completeness. Meningiomas, out of these, make up about a third of primary brain tumors, equals about 25,000 per year in the United States. But the problem with Torcular meningiomas is that they are super rare. The age distribution and gender distribution follows normal incident rates, which really means that females are disproportionately affected, which likely is due to hormonal effects, and especially in Torcular meningiomas, there seems to be an enormous preponderance of female patients affected. Amongst the meningiomas, you need to realize that the vast majority is supratentorial, only 10 to 13% are infratentorial, and amongst the infratentorial tumors, this makes about 1 to 0.1% of tumors. So it's really a rare bird, but it's an important one to come across, because if it hits you, you need to be prepared. So what about the normal anatomy here? We all know that Torcular is the junction of the superior sagittal sinus and transverse sinus, and you can see that it takes up the straight sinus coming down, and then continues sometimes as a cerebellar sinus, but also usually diverts laterally into the transverse sinus. And there's usually a dominant one of the two transverse sinus visible. The external landmark is the occipital protuberance, and we use that for surgical purposes. Your blood supply to this area, to the meninges, arises from the middle meningeal artery, the occipital artery, or meningeal branches of the vertebral artery. Now, what's so important here is the pathological anatomy, and Torcular meningiomas are not subclassified themselves, so most people use a classification system developed from parasagittal meningiomas. This system by Sindhu is very helpful, breaking it down into about 6 types of tumors. Top panel number 1 is a tumor that comes and just attaches to the outer wall of the sinus. Then it invades the lateral recess, type 2. It invades one wall, type 3. I think those are the most important ones to remember. And progressively, type 4, it invades 2 walls or can even completely obstruct the sinus, and that will change your surgical strategy. From a clinical perspective, I think it's smart simply to say, is there partial obstruction or is there complete obstruction? And if there is partial obstruction, is it more or less than 50%? So I think one problem is obviously the location and the venous relevance in this arena. So you need to study your venous anatomical variants. We'll go to that in a second. Patients usually present with occipital lobe symptoms, which are visual, can be a visual aura, seizure, can be visual compromise, blurry vision, or hemianopia, or with cerebellar signs, which are by compression, ataxia, dysmetria, and nystagmus, or ICP elevation, mainly causing headaches and associated symptoms. Now, when you think about these lesions, you really need to study your venous anatomical variants, and especially the one second from the left that is mentioned here is the one we all know best. The normal superior sagittal sinus drains into one dominant transverse sinus, which is usually on the right side, and that is found in more than 50% of cases. But there are unusual draining patterns, either duplication of sinuses or atresia, as frequently seen as in 20%. And this is where you need to pay huge attention at the beginning of your case. Now, when is surgery indicated? First of all, resection is indicated, I think, only for symptomatic patients. I think below the age of 65, sometimes we operate on older patients if they are fit. And they should have either badly symptomatic tumors or enlarging tumors. And I think they need to be medically fit for surgery with the KPS above 70 is our average takeoff. I think surgery is not indicated for calcified tumors in this location or tumors that are not growing and just incidentally found. These patients should be observed with serial imaging every 6 months. And if the patient has significant comorbidities, this may not be the patient to try something out on. So symptomatic patients that are older or have comorbidities can be shunted if they have hydrocephalus, and then one can think about radiation therapy for the remaining period of their life. Now, learning points. I think the tumors that can be considered for resection are the ones that have already occluded the sinus. That's a good starting point. And the ones that have collaterals developed, and you can think about yes or no reconstructing the venous outflow. The more difficult scenarios where tumors have partially occluded the sinus, and here you need to really set your goal for surgery. Sometimes it's wise to go for subtotal resection followed by watchful waiting and possibly radiation. I personally do not recommend sinus wall resection and reconstruction in high-grade occlusions. If a single wall is affected, that may be different. I'll show you the data in a minute. So what do I do? This is high-risk surgery, so I think you need to spend the most of your time on pre-surgical imaging. And I obtain plain X-rays to see is there bony erosions, possibly paraosseous venous channels, and then I get everything that's on the market, CT and CTVs in 3D rotational modes that show you venous anatomy in an overview, MRI scan for extent of tumor, but you really need a DSA to assess tumor supply and collaterals, because the problem with MRAs is that they are flow-based studies, and if you have low flow status, you may get a signal dropout that tells you there may be no flow, but in reality, there is still preserved anatomical flow. I think a PET is not necessary, but some people get it for pre-surgical staging to know how aggressive the lesion is. And then I follow an advice by Yajagil. He actually flips the sides of his MRI scans or CAT scans in the operating room, and I just print them swapped left to right, the same way I would position the patient in the operating room, and then I draw on my printout what is my surgical strategy, because I think this is such a complicated case that one needs to really have this staged out in your head before you get into the operating room. This is a similar paper that was published by Nagakawa that showed one of these pre-surgical scans and DSAs that gave him an idea about how to approach this tumor. They made a beautiful conceptual drawing, and it helped them really to stage the procedure. Now, why is a DSA needed? I said you need to define your dural sinus. You need to really study the collateral venous drainage, and you need to look out for significant transosseous and scalp drainage, because it may actually go laterally, and this may be the brain passage the brain vein lives on. So think about this. Even the scalp flap and the craniotomy must be tailored to preserve these only outflow channels that are left to the brain if your torcular is already occluded, right? And in addition, you need to look at tentorial channels. One other thing for pre-incision adjuncts, you should not forget, this is complicated surgery, so give your anesthesia team the time they need. I think large bore access, precordial Doppler, as we said, for possible air embolus, get a large central short line, a cordis line in for possible aspiration, keep your height of bed slightly elevated, and the anesthesia team needs to exactly know where the button is to bed control in case you need to change this, have fluid ready to flood the surgical field, and clamps in case you need to temporarily occlude or permanently occlude a large vessel. I don't use lumbar drains or EVDs because I think this is largely extraaxial disease and it's very superficial, but it has been described in the literature. I use definitely brain relaxation, 100 grams mannitol, 20 Lasix, 10 of Decadron is my usual cocktail, and I hyperventilate the patient to get some vasoconstriction to get more volume out. Now, I included this slide just for completeness, how to manage air embolus. It was well addressed by Henry's talk. Please look at this. It's a great article in the Gardol Neurosurgical Atlas and tells you how to handle this in case it does occur. I think you need to be prepared for it. In terms of surgical strategy, I think all positions are possible that work in your hands, but I urge you to think about this carefully up front. Nobody has the best answer for this one. But I think you need to think about your incision, and I definitely prefer a linear incision over a trapdoor or a barn. The reason is you can maintain better venous supply. So my recommended position for someone who does this first time is to do 3/4 prone. I stand to the shoulder of the patient on the right side of the images, so I look upright as if the patient's head is in front of me pointing up, normal anatomy. I think the position is great. It avoids rainous venous pressure from abdominal chest compressions. It reduces your risk of embolization. You can drop the head easily. The head should be turned slightly, and the tumor should be the highest point in your surgical field. Tape the shoulder down, otherwise it drops into the field and you have obstructive view. I think most of the torcular meningiomas require supra and infratentorial exposure. I start infratentorially, and the reason really is that I'm more awake and alert at the beginning of the case, so I'm a little bit more careful and get over a little bit of a break when you do the supratentorial component, which is more routine afterwards. But that's a standard opening. For the supratentorial component, which is usually more relevant, I think make this as conventional as possible. So use your image guidance and just think about wide durotomies. On the left side, you see you want to have clear margins of your dura. You want to tilt the dura away from the sinus. And then I use some stationary attractors with very little pressure because you need to be careful about the occipital lobe. And you need to prepare for double ligation of the sinus to make sure you have no bleeding into the field. Prone works also well. This is by Tetsuo Kano's atlas. Here, gravity helps you to have the brain drop away from the sinus. But as you can see in the picture, I think the opening is a little bit small. Aim for 2 centimeters of normal dura around your lesion. Now, how about sinus invasion? There's a great set of papers in respect to parasagittal meningiomas. This is one from Teed Madison that tells you good strategies and techniques. What I want you to take away from this is I think type 1 tumors are extra venous, so they don't need any grafting. Type 2 and 3 tumors just infiltrate the upper corner and one wall. These are the ones where you can think about dural patching, and you need to prepare for this. Grade 3 and 4 tumors, I think, are largely non-suitable. Now, cases to learn from for grafting is one of this. There's a fantastic paper said by Lalekham Shekhar that shows you this is a tumor on the left upper corner. You see that infiltrates one of the transverse sinuses, but doesn't occlude it yet. Here, the strategy is, expose the tumor as much as you can in the middle panel on the top, and then you plug the sinus left and right with a piece of Surgicel to allow you to remove the intravascular tumor component and patch a piece of pericranium into it. So this is a relatively simple repair with a simple patch for one vessel axis only. When it gets more complicated, like this tumor that is largely intravascular, you have a bit different problem. Here, the transverse sinus is not occluded, but the straight sinus is already occluded. So I personally think pick your battles wisely. Large part of the tumor here is extravascular. I would have resected that part. Ekkehard takes you through the steps of how to open the sinus in all 3 walls and take out the tumor and patch up a repair. I included this for you to review. The reason why I don't advocate for a 3-wall repair of the sinus is that patency is really limited. More than 50% of sinus reconstructions will lead to complete thrombosis, even in expert hands. And Ekkehard is one of the best guys out there doing this. So I think this is not for the beginner, but if you have good vascular training, by all means, it's possible. Now, how to deal with gigantic tumors if you're facing like seemingly impossible problems like this one. I think the most important lesson to learn from a case like this is define your goals, because it is essentially impossible to achieve a clear gross total resection in a tumor of that size and extension. So here, subtotal resection followed by radiation really equals quality of life. And I think De Bernardi discussed this very nicely in their paper, where they show over the last 10 years, patients now have increasingly the expectation of no morbidity associated with surgery, and they are much more willing to accept a subtotal resection in the setting of adjuvant therapy. Now, I want to take you through one of my own cases recently, which combines all these questions. This was a 21-year-old female student that presented to an outside ophthalmologist only with 5 months of blurred vision, nothing really else. They picked up a left-sided visual field defect, blurriness, and some progressive headaches. She had no past medical history of any relevance. She only took non-steroidals over the counter. But on exam, we found bilateral papillary edema and a hemianopia with no other deficits. So this is how the patient was referred to us. And this was the outside hospital scan, where you can see on pre-surgical MRI scan a profound tumor originating right side occipital lobe, then growing into the sinus in the midline and extending into the transverse sinus on the left line, reaching all the way up to the jugular bulb. And that's a formidable challenge, I can tell you. The best thing about these tumors is that they are so rare, because you really are challenged to your best of abilities. I got pre-surgical studies, including CT and CTA and CTVs. And as you can see, the tumor itself was not very hypervascular, but on the second panel, left upper corner, we saw interesting tentorial collaterals that had formed on the side of the occluded sinus. And the CTV below shows you that the sinus was essentially still patent, which creates a huge problem because the confluence was working and you didn't want to lose it on the way. So my first surgery for this one was debulking the right-sided tumor through a standard craniotomy, which I brought to the midline to see the sinus exposed. And I was able to take the entire extraaxial component of the tumor out, but I left the wall of the sinus standing in the middle. And I said, I'm going to restudy this and observe how fast would this sinus possibly close. So 6 months later, the patient presented with 2 days of intense headaches. And as we restudied her, we noticed that, yeah, there was some re-expansion of tumor, as you can see in the middle panel on the top. But now on the CTV, right lower corner, you see that there was actually occlusion of the confluence with the superior sagittal sinus being out and the transverse sinus on one side being out. I got a DSA that showed me that the right-sided transverse sinus was still open and functioning. Everything else on the left side was out. So we took this patient back to surgery, and now I did the whole approach, again opening supratentorial, infratentorial, bilateral, and we were able to resect the entire torculum by placing silk sutures and wet clips above and below. And we followed actually inside the transverse sinus towards the left side up to the jugular bulb, where we reached the tumor plug. And as we received back bleeding, we just put a piece of surgical in there, put a clip over it, and left it as is because it deemed to be irresectable at this point. Intraoperative pathology here showed the tumor was more aggressive than expected, WHO grade 2 with lots of mitoses. So we knew that this would require adjuvant treatment. This is what we did. Post-op 2, we had 3 months of follow-up to just see how the post-surgical bed would settle. In the left upper corner and in the right lower panel, you can see there's essentially no tumor left except the portion sitting in the very corner of the transverse junction to the jugular bulb, but we had to cover the entire surgical field with external beam. We did 60 grays in 30 fractions because it was meant to be atypical aggressive meningioma. And just to give you an idea, the local control rates for grade 2 meningiomas should be as high as 90% at 10 years. So I think leaving a tiny piece of tumor behind here was the right decision to preserve function, because in both surgical cases, the patient was able to go home on post-op day 3 with no deficits. So what have we learned from this talk today? I hope that you see torcular meningiomas are rare because they are less than 1% of skull-based meningiomas. They are highly complicated, and this location requires diligent study of your pre-surgical imaging, especially the veins. And this is not the case to save money on. I think you should use all imaging modalities available. I think you need to plan your surgical approach really well individually. Surgical treatment is the treatment of choice in suitable patients, but I think the primary goal would be preserve sinus patency if it's still patent, and grafting remains controversial. There's a fantastic chapter by Ekkehard in Lee's book by Springer that I would recommend to everyone. I think occluded vessels, including the torcular, can be safely resected, but be careful what the goal of resection is. I think quality of life is what matters most. And remember that margins can be treated with adjuvant radiation and achieve exquisite local control. So thank you very much for joining me, and I'm open for questions.
Rames, you're mute.
Thank you very much. That was a brilliant talk. Professor Kasper, really brilliant in anatomy and practical and surgical tips. And any comments from the panelists or participants?
I have one comment. Actually, I want just to convey a message from our colleague Ibrahim Subeh about the concern of shunting, not for the specific case of falcotentorial, but all the talks about pineal and previously craniopharyngioma, that people in the, especially in underdeveloped or less developed country, they put the shunt as a treatment first line and then they go for the lesion. This is not appropriate practice, and you can always put, if you need an EVD, and before you commit your patients for a full shunting for life. This is a message I think will be stated for the trainees. For the falcotentorial, I agree with concern. Whatever the expertise you have with all publication, especially when it comes to the 3 major venous drainage involvement, to make the repair on the 3, they all entail some even temporary occlusion, and this will affect the outcome of your patients. And especially on that case, the bilateral occipital venous congestion that will lead to a major cortical blindness, which the patient will never
recover from.
Accepted, okay? And that's why we have to understand there is something called adjuvant treatment for some cases that you want beyond that safety. And I agree that patient outcome should be the #1 for you. I agree with this completely. Thank you, Ek, for the presentation.
Technical question, Ek, it was excellent summary. How do you plug the straight sinus from anterior? A back bleeding from the straight sinus. I always fight with this, you know.
Yeah, so I personally don't, but when I read through Shekar's papers, you know, he either uses a small piece of Surgicel that he puts into the lumen, and then at the end of the case, when he has done his grafting or his bypass, he pulls it out. That's the last move he does before he closes the access point. There are ways that you can put in a plastic shunt similar to people that use carotids, but the problem with these shunts is they are low flow, low pressure, so there's a high chance that they actually don't maintain during the case. I read up on this, and people are willing to fully heparinize patients for shunting, I'd find that rather daring in the setting of a large P. fossa operation to put the patient on systemic anticoagulation. So what I've done is I pre-surgery put the patient on aspirin, that they have slightly improved rheologic properties. If I put a temporary clip in, hopefully the collaterals are less resistant. But I don't put a plug into the straight sinus. Honestly, I stay away from the deep structures. If it's occluded, I take it, but I would not attempt to reconstruct this. The better I get in surgery, actually, the less daring I am, which is counterintuitive, but I think it pays off for the patient because 50% patency is fantastic in gifted hands. And if someone like Sheka can make a few of them last forever, that's beautiful. But if one of them goes down, you have a real disaster. And they are so rare that you've only done 10 in the last, 5 years, I'd say. I wouldn't try new things on a case like this. If you have a large series of parasagittal meningiomas where you can practice grafting on the superficial veins, I think you learn a ton, you work out the workflow in your OR, and if your team is up for it, you are much, much better posed than if you haven't done this much. So I just want to caution everyone that I think grafting, yes, is possible in gifted hands, but it's a matter of intense debate, and even exquisite centers do it rarely.
Yeah, I agree. I would also suggest if there is an invasion and a reconstruction has a high risk for the patient, for this is a benign lesion, so we always wait until the sinus is completely closed, and then you can come and make a second surgery. I think there's no need. Even some people say you re-implant bridging veins into the sinus. This is so thin, the veins, and this to suture, it's difficult. So also, I always ask myself, if this would be my wife, would I do this surgery? I said, no, I would not do. I just wait until it's completely occluded.
I have to concur with this because you see, if you give it time, there is always a collateral to build up. But that time you can sacrifice the thrombosed vein.
Yes, and you have to be very careful with these collateral veins. That's why I always make an DSA before to see the dynamic in which direction is the blood drain, so that you be sure that you do not close these collaterals. This can also be a disaster.
Actually, Dr. Broggi has nicely shown in previous talks that maybe the use of ICG to see flow directional veins will help in especially parasagittal meningiomas, but you may also use it in this one to make sure that your surgery maintains flow.
Yeah.
Can I ask you again, when you resect totally occluded sinus, as you say, a lot of the collateral will be really in the tentorial leaves near the occluded sinus. So when you resect the occluded sinus, you shouldn't go wide, otherwise you will compromise a lot of this collateral. The problem we observed in our tentorial series that the intrasinus component has a very low, slow growth rate, and most of the recurrence come from the external component to the sinus, even if the case that you have shown. So I'm not, even when you totally resect what seems to be occluded torcular or sinus, there will be still a potential for recurrence, and maybe adjuvant therapy should be considered as well.
So that's true. That's a matter of debate in atypical meningiomas all over the world, right? Grade 2 meningiomas have a gross total resection success rate. We have done this a lot, but even in patients that had gross total Simpson grade 1 resection, 10% recur at 10 years. And it's not clear, is this more global disease? We just didn't see it under the microscope. Or is it we left a margin that was positive and it wasn't Simpson grade 1? I think in these skull-based meningiomas, the whole Simpson grading doesn't really work because that was meant to be a convexity meningioma with dural sleeve resection, which you don't get in this location. So I agree with you. We should be more conservative and consider adjuvant treatment. In general, I would give adjuvant treatment only at documented progression of the residual. I wouldn't give it, just post-op when I have a clean field. So then you can get your MRI scans every 6 months and you radiate when you see progression of the residual. But in her case, in my last patient, she was young. She clearly had gross disease left at the level of the jugular bulb. I am contemplating sending her to Bill Coldwell to get a bypass for the jugular in case this occludes and she becomes symptomatic. I can't do the lateral portion. I'm not experienced enough in big venous bypass grafts or lateral skull base resections for this degree. But maybe you have other ideas, please let me know.
The other technique we used was endovascular stenting of partially occluded sinuses, especially those who present with severe intracranial hypertension and edema, and then resect around the stent or use adjuvant treatment.
Yeah, I'm not a fan of transvenous stenting in tumor cases. Makes your future surgeries a nightmare. And in addition, you may cause emboli as you place the stent and then the tumor embolus travels. So I stay away from this, but I've heard about it. And I think in select cases, it may be suitable.